Hello, everyone, and thank you for tuning in. I am Danny Donaldson, and I'll be presenting my pulmonary case today. I'll start with the subjective information, then the objective, then we'll go to assessment, and last but not least, we'll discuss planning. So, to start, my patient came in with shortness of breath and a cough that worsened with sputum over the past 4 days. That was the chief complaint. So, history of present illness. My patient is an 83-year-old female. She has a history of COPD and hypertension. Today, she came in with her daughter and to the clinic, and she presented with insidious onset of dyspnea. For 4 days, she has experienced worthless, worsened breathlessness and increased cough. She produced yellow sputum from her productive cough. She suffered from intermittent chest pain also during these episodes. She reports a low grade fever and generalized fatigue. Mild symptoms have gradually worsened over the past few days. Her cough intensifies during the mornings. Her difficulty in breathing restricts daily activities. She denies any recent travel and contact with individuals who have been sick or who are currently sick. Her condition deteriorated despite the usual inhaled bronchodilator regimen that she currently takes. So, her past medical history includes COPD, hypertension, and also osteoarthritis. Her past surgeries include a total hip replacement in 2010. Allergies, she has no known allergies. So, as far as her social history, she's a former smoker, 45 a 45 pack year history. She quit about 10 years ago. She lives by herself and she lives inside of a senior apartment complex. She has an occasional glass of wine with dinner, limited physical exercise due to joint discomfort also. So when it comes to review of systems, she reported fatigue, mild fever, and reduced exercise tolerance. When it comes to her general assessment, as far as her head, ear, eyes, nose, throat assessment, she denied sore throat and any visual changes. Uh, for her musculoskeletal, she did report stiffness in the mornings in all of her joints. She stated that it was peripheral. Neurologically, no dizziness, no focal weakness. As far as her cardiovascular, no chest pain at rest. Um, and also, she did report occasional palpitations. Uh, Respiratory, um, she reported increased shortness of breath, productive cough, no hemoptysis. As far as gastrointestinal, no vomiting, no nausea, or abdominal pain. As far as objective, her temperature was 103.4, 99 beats per minute. Her respiratory rate was 18, and her blood pressure was 152 over 93. She did report taking her medications this morning. Her oxygen saturation was 92. Okay, so her general appearance, she does appear kind of frail. She was seated comfortably in the examination chair. No acute distress at this time. So, first, assessment. Uh, I inspected her lungs. So, upon inspection, there was the use of accessory muscles noted on deep inspiration. When it comes to palpation, no tenderness noted on her chest. Auscultation, decreased breath sounds in the right lower lobe with inspiratory crackles and scattered wheezes bilaterally. As far as the cardiovascular system, there was a regular rate, no murmurs or gallops. Peripheral pulses were palpable and symmetrical. As far as her abdomen, it was soft, non tender, and non distended. Her extremities, um, mild, bilateral, lower extremity swelling, no cyanosis, no clubbing. Um, as far as her assessment, okay, okay, so let's get into the labs before the assessment. So she did have a CBC. It showed mild leukocytosis with the left shift. Her BMP, everything was within normal limits. Checks X-ray yielded a patchy consolidation in a right lower lobe, suggestive of an infectious process. We were able to get the X-ray done at the clinic. So, okay. So as far as assessment, so let's get into diagnosis. So I chose three different differential diagnoses. The first was acute COPD exacerbation. The second one was CHF. And third, bronchitis. Her primary diagnosis I chose was community acquired pneumonia based on a background of COPD. Um, Supportive evidence included a productive cough, a low grade fever, increased difficulty in breathing, and also intermittent pleuritic chest pain, also the x ray. Okay, so as far as planning, so diagnostics, so, oh, no follow up with labs. Okay, so her therapeutic interventions included um, initiate antibiotic therapy, which she received levofloxacin of 750 milligrams once a day for 7 days. She was told to continue inhaled bronchodilators. Um, she was also um, prescribed oxygen to keep her SpO2 level above 92, and also antipyretic support with the acetaminophen 1 gram um, by mouth when needed. So as far as her education, she was educated on the value of medication adherence and proper inhaler techniques. Um, she was instructed on signs of worsening respiratory distress and when to notify 911. She was educated on we emphasized the role of fluid intake and rest to aid in recovery. We provided smoking cessation reinforcement despite previous cessation. Also reviewed home care measures and went to seek further medical attention. So thank you guys for tuning in. I am Danny. Thank you guys.